Happy day to all. This is Dr. Nivedita, co-founder and chief physiotherapist of Sri Ahana Physiotherapy Clinic and Academy. This video is on static stabilization of the glenohumeral joint. We all know that the glenohumeral joint is a ball and socket joint. The glenoid fossa is only 1/3 the size of the humeral head. So just with a bony articulation, it is evident that this joint is not a stable one. So we need few other mechanisms that can contribute to the stability of this joint. Here, when the arm is hung by the side, gravity exerts a downward pull on the humerus. So we need a cranially directed force that can put the joint into equilibrium. That is, somebody has to pull it upward and keep it stabilized. So we all might think that this glenohumeral joint is being stabilized by the muscles like supraspinatus, your deltoid, your long head of biceps and triceps that are surrounding the shoulder joint. Conversely, a research study has proved that in a static unloaded arm, that is when there is no weight in the arm, what happens is these muscles are remaining electrically silent. That is, they are not actively contributing to the joint stability. So, the process of glenohumeral joint stabilization is not an active one. It is clearly understood that this is a passive one. This passive stability is provided by the rotator interval capsule. The rotator interval capsule is nothing but it is a gap between the subscapularis and your supraspinatus muscle insertions. This gap is being filled by structures like your coracohumeral ligament, your tendon of biceps, and your superior glenohumeral ligament. When the arm is hung by the side, these structures are taut, they are tight and they provide passive stability to the glenohumeral joint. The rotator interval capsule has both magnitude and orientation. So, the resultant vector of gravity and the rotator interval capsule exerts a compressive force on your humeral head and keeps it stuck to the glenoid fossa. So this is how stability is being provided by the rotator interval capsule. There are few other mechanisms like the negative intra-articular pressure and the inclination of the scapula that are contributing to stability. The negative intra-articular pressure creates a vacuum within the joint that keeps the humeral head sucked in. So this is how it provides stability to the glenohumeral joint without being inferiorly translated. The orientation of the scapula is such that it is slightly tilted upward. So, the glenoid fossa is also tilted upward and it gives a bony restriction for the humeral head and prevents it from translating downward. So, the humeral head doesn't go downward. So, this is how the inclination of the scapula helps in stabilizing the joint. The glenoid labrum also plays an important role by deepening the socket and allowing more space for articulation of the humeral head. Is loaded. When the arm is loaded, the passive forces become inadequate and the supraspinatus has to give its active assistance in stabilizing the joint. This is because the supraspinatus has its attachment to the rotator interval capsule. If the supraspinatus muscle is not reinforced in a loaded arm, what will happen is there will be more amount of stretch being put up on the structures of the rotator interval capsule. So they enter a region of plasticity. So they become inefficient to provide passive stability to the joint and that results in subluxation. In case of brain injury and in case of stroke, we can see subluxation of the glenohumeral joint due to these factors. Or when the capsule is torn or vented, when the vacuum is not there, there is more chance for the humeral head to undergo inferior translation. So I hope with this video, static stabilization of the glenohumeral joint was clear. Thank you.